one of the 3 parts. It's recording now. So this meeting is going to be part 1 of a 3-part series, and it's no way means like supposed to be prescriptive in the way you conduct your SMRs, but it's more of an introduction to what SMRs are. So today I hope to cover what an SMR is and what it's not, what tools you might find useful to find patients for your SMRs, who can conduct the SMRs and how long they should take, and things that we might want to consider more generally in an SMR as well. So why are we talking about SMRs? Well, mainly because it's in the Network Directive Enhanced Service, so your DES contract. And essentially for those practices in the PCN that have opted to sign into the DES, it becomes part of the practice primary medical service contract. I've included the links for the DES and as well as their specific guidance on how to undertake SMRs. But more importantly, the reason we're talking about SMRs is because when conducted well, they really have shown to improve patient outcomes, reduce things like hospital admissions, and they've been shown to help patients get better value from their medicines. So as a result, if it's done well, it may save time in the future and even potentially lives. So that's the main reason. I thought I'd share this cartoon because it makes me smile and makes me think about why SMRs are so important. Just in case you can't read it, it reads, "You seem to be suffering a reaction from the amount of medication you're taking. I'll see what I can prescribe for that." And so polypharmacy begins. So what's considered an SMR? It's a structured, holistic, and personalized review of all the medication a person's taking, including any other, OTC meds, herbal medication, as well as any hospital-only medication as well. And it's really what we're asking is you to critically examine a person's medication with the objective of reaching even an agreement with the individual about their treatment. The most important thing that you must include in your SMR is to involve the patient. So you're making decisions together about what's important about the medication and what works for them. So really shared decision-making principles should really underpin these conversations that you have. So I often get asked also how to document hospital-only medications in EMIS. So I've just screenshotted the process and I thought I'd go through it quickly because part of the SMR, you might want to put patient's hospital medication onto the system as well. So you would just add the drug as an acute medicine as per normal, and then you would go to the medication tab and select the drug so that it's highlighted. Then just click on the issues and a new window will appear. And I've screenshotted. So you then just select on change all and then select hospital no print from the drop-down menu. And then you can adjust the issue date according to the clinic letter. And then it will appear under hospital issues in EMIS in the medication tab. So it's just clear that it's just for information and you wouldn't ever be able to issue a prescription against that. So coming back to SMRs, talking about what an SMR isn't. So it isn't simply about the act of reauthorizing repeat prescriptions or just tidying up the medication record or just linking the medications to a problem. This said, these are all probably things you would do in an SMR in the more fuller sense, but it's not just simply doing those things. Additionally, it's not asking the patient, is everything all right at the end of the conversation? It really is about involving them in the conversation as well. And it's not just reviewing specific medications as part of a long-term condition review. Because an SMR must include all the medications a patient takes. And it can't be just a notes review. Again, you must involve the patient in this review. So the DES actually outlines patients that are appropriate for an SMR, and it suggests that patients living in care homes and patients living with complex and problematic polypharmacy, specifically those on 10 or more medications, should be offered an SMR. Additionally, if patients are taking commonly associated medications with medication errors, which are specifically outlined in the medication safety indicator document, which I've just linked for you. Examples include, patients on NSAIDs and renin and angiotensin system drugs or diuretics, or people who are on NSAIDs and prescribed with, anticoagulants, people like that. Also, it specifically mentions women on valproates in the DES as well. So I've just put a link to the guidance for that as well. Other patients that are listed in the DES include patients with severe frailty, who are particularly isolated or housebound patients, and patients with recent admissions to hospital, and those with recent falls, as we know that any transfer of care setting puts patients at increased risk of harm, especially from home to hospital and vice versa. A new indicator that was included when they updated the SMR DES this year in March was to include patients on potentially addictive pain medicines, such as opioids, gabapentinoids, benzodiazepines, and Z drugs even. So how are we going to identify these patients? We may identify them proactively, and there's a couple of ways that might happen. So there might be the call to action letter, and this is where the government might suggest that specific groups should be prioritized. And as an example, we had this at the beginning of COVID, around March, April last year, where we were asked to prioritize your care home patients and do SMRs on those patients as a priority. And then we have specific tools in practice for finding patients, and we'll talk about this in a little bit. There are also some patients we might identify in a more reactive way. For example, complex discharges, or if a care home or your colleague in practice asks you to review a patient's medication, you might want to take that as an SMR as well. So as I mentioned, there's quite a number of tools for proactively finding patients for SMRs in practice. And the one that we are actually championing is the CLIPS SMR Live tool. But there is, the electronic frailty index you could use Princer, you could use the NHS BSA indicators, which is a dashboard and EPAC. There are Arden searches, there are KEG searches. The KEG searches have actually had a few mixed reviews, so I'm not sure about them, but they're available, and MDT meetings and clinics as well. So it doesn't really matter which tool you use, but the really important thing is when you do an SMR, that you actually code it correctly and record clearly that an SMR has been undertaken. There's also many templates you can use to record your SMR as well. Things like Eclipse or the SMR reviews, or EMIS have one as well. And I think System 1 and Ardens also have one as well.
At this stage, can I just make a couple of points?
Yeah, sure.
That is, there's still a number of attendees who have not put their name, where they work, and their email address within the chat box. So that will be very valuable. Secondly, there are some people who have joined after you started, so they may not have gathered that if they can put any questions they have within the chat function, and if everybody could keep an eye on the chat function and sort of put down anything within it. So thank you, Rima. Sorry to interrupt.
No, I can't, just so you know why Mohammed is helping me here, is because I can't see anything other than myself presenting. So I have no idea what's going on in the chat box. So coming,
not a lot, Rima, not a lot.
okay, good. So coming back to tools for finding patients. So I'm just going to quickly run through Eclipse SMR Live, because that's the one our team is really championing. And I've just got some slides to show you how it might be useful as a tool, because this is something that all practices in our area should have access to. So this tool is quite clever, as it allows you to prioritize patients according to risk. And the way you access this is you just log on to Eclipse in the usual way, and then you click on the SMR live function, which I put an arrow to, or a hand to. Then you select your practice or PCN from the drop down on the top right hand corner. And then you can either view your caseload, so all the patients that are that need a review in your practice, or you can review them as a priority SMR. So this list is prioritized. You can even choose to view them by different categories, like your housebound patients, etc. So let me show you what it looks like when you have a priority list. So the priority list is re-stratified according to a scoring system, which is defined by your SMR points. And the points are allocated to a patient based on things like recent admission, degree of polypharmacy, their anticholinergic burden, their frailty index. So there's quite a lot of things that make up the point, all the points that a patient might get. The SMR points are then used to rank these patients within the practice, and then the ones that are at the top, which have the highest potential risk of harm from medicine. So this is a really, really good way of making sure that the patients you most likely are going to benefit from an SMR are identified first. This list can then just be exported into Excel, and if you prefer to save the list in practice, if there's more than one person working on it, it might be easier to do that. And then for EMIS practices, the reference number that the list gives, that is the EMIS number itself in practice. So it's easy to identify your patients in practice. I've just put this slide up so you can see the type of points Eclipse SMR gives to each risk, so to speak. So it just gives you some idea how they might add the points up. But, just a quick glance, really. You then have the option to either use the SMRF template, and when I say SMRF, it stands for Structured Medication Use Reviews. And follow-up template, I've forgotten, I think it says, yeah, it's on the top of the slide, and follow-up template in Eclipse to document the review. Or alternatively, you can just use a template of your choice, like the Ardens or the EMIS or the KEX templates. If you wanted to use the SMRF template, you would just click where it says Structured Medication Review, and then you'll be met by this page, and it would just take you, so you can just add notes for each of the drugs by clicking on the down icon that you can see at the end of the end of each drug, and you can complete the action plan, and then you'll save this as a document, as a PDF document to the patient's record. And then what you would do is just make an entry into the patient's record and read code it to say that an SMR has been done. As I said earlier, this is just an example of a template that you could use. There are loads of templates you could use, that you just pick one that works for you. But really, the SMR Live tool is what we want you to use in practice to identify your patients more than anything else. This is just a quick overview of Eclipse SMR, but just to let you know that they do have their own user guides and videos on the system. So if you want to, sit down with that and have a look, it just goes step by step how you might want to use the tools that are available. So now moving on to who should take an SMR. So the DES actually says that all GPs and advanced nurse practitioners who have the correct experience, as well as clinical pharmacists who have either completed or enrolled onto the pharmacy care, pharmacy educational pathway or similar training, can undertake SMRs. So this includes any IP pharmacists as well. So when we think about planning an SMR, it's really important to consider a few things. So where are we going to see these patients is really, really important to think about. So in some cases, it might be in the patient's home, or it might be in the care home. You might choose to take it under a video consultation. So there's lots of options where to do it. And then you might want to think about, as a practice, when are you going to take these SMRs for your patients? Some practices might wish you to take SMRs as and when a patient is due for their annual review of medication. So you just do it, instead of doing the annual review, you make it a more involved SMR. Other practices might want you to work through the priority list and just do it as the priority list. So that's the kind of conversations you need to be having with your PCNs and practices to work out how you're going to do that in practice yourselves. So how long should an SMR take? Now, this is a really, really tricky question, and it's a question we get asked quite a lot. And it's really tricky to answer because much of it really depends on the patient that you're reviewing as well. So I think what's really important is to have a flexible approach when you are undertaking SMRs. And you might want to also bear in mind that there might be a number of steps involved in doing a single SMR. For example, in the first case, you might want to do a review of the notes and prep before the patient. And you might want to do this a few weeks in advance, because you might want to identify any bloods or any monitoring that you need to do for the patient and get that organized ahead of the review. Then with all the steps and, including all the anticipated workup, we anticipate probably that your review will take an hour. Now, some might be quicker, some might take considerably longer, but these are involved pieces of work if done properly, and the value really lies, rather than just treating it as a tick box exercise, that you try and get as much as you can out of these reviews. And one of the things you might want to do, if you feel comfortable to do, is, you might be able to do some of the long-term condition reviews within the SMR as well. But again, that's something you might want to talk about with your practice and clinical leads, and see what works for you. It is also individual, because you might not feel confident to, doing a diabetes review or asthma review. So it's really open to how you want to do it. So as I've already mentioned, in preparation for your review, you might want to do a few things. So you might want to make sure all your monitoring is up to date. Read any recent discharge letters or any clinic notes. You might want to have a look at the advanced care plan if the patient has one. And the other thing I would recommend is mapping drugs to indication, because that really gives you an idea of why something was started. One of the questions we often get is, how do I find when a drug was first started? I know this would be really, some of you would be really knowledgeable how to do this, but some of the people who are new to EMIS might find this tricky. So I'm just going to spend a few slides just quickly going through that. So there are two ways that I would do it personally. And I give you two ways because sometimes one way doesn't work. Like, you might not be able to find it one way, but you might find it the other way. So the first way I normally do is I click on text search in EMIS, and then you get a pop-up bar, and I'll write the drug that I want to search. And then I'll just literally scroll to the first entry for that drug and see if there's an entry there. If that doesn't work, I might try going to the medicines tab and then right-clicking on the drug and selecting it, and then clicking drug history, and then finding out when it was first prescribed through that route. And again, just then going back to the consultation tab and seeing what the GP has written, why it was started. If there isn't a GP record around the time the drug was started, I would then go to the documents tab and check any clinic letters or discharge letters at the time to see why it was started, and hope that there's something documented there. But if everything else fails, and even when I do use these methods, I generally do check with the patient what they think the medication was started for and who by. So that's a whistle-stop tour of how to find drugs. And then more generally, things I would consider to do in an SMR. Sorry about the busy slide, but we'll just go through it very quickly. So I'm sure some of you do this anyway for all of your contacts with patients, but for an SMI, it's really, really important to check before you even begin whether the patient has capacity to be involved in these conversations. Otherwise, you might need to get a next of kin or family member involved in their conversation. The next thing I would do is always check allergy status, and it's a really good time to make sure that you have this documented in your notes, and check that it's up to date as well. And then I would always think about adherence to the medications that they're prescribed. And when I check adherence with my patients, I tend to do it in a really non-confrontational way. So instead of saying, do you take this 4 times a day, I would say, well, something like, do you manage to take your, how often do you manage to take your clopidogrel, say? And that really gives patients a chance to say, well, actually, I take it about 3 days out of the week. And it's a little bit less confrontational than just, expecting them to take it as we prescribe it. The other thing I always look at is their incontinence status, because often a lot of the medication we prescribe does impact their bowels and does impact their urinary systems as well. So we have to be mindful of their continence status. And similarly goes for, diet, fluid intake, swallowing status, that they really do impact on how we give medications. So it's really, really crucial to know that at the outset. Things like mobility and weight bearing and falls risk. So, a lot of the medications we prescribe have huge implications to fall risk, your anticholinergic burden, for example, and then you've got, your Z drugs, your benzodiazepines might contribute to that, blood pressure medication. So, understanding their frailty is really important, because it really does change how you might view a patient. And then obviously observations, blood pressure, pulse, weight, that kind of thing, and smoking status and alcohol, all of those things. And then another thing that I nearly always check in these reviews is whether medication is being given covertly. And these are especially important for those patients that don't have capacity, where you're asking these questions. And one of the things that we would need to check in these kind of reviews is whether, something like the mental capacity assessment has been formally done for the patient, the best interest meeting, been undertaken to look at whether these covertly administered drugs are appropriate for the patient. Checking things like blood results, investigations, we talked about that a bit earlier, and then also checking for like interactions and any side effects the patient may be having, and looking at renal and hepatic impairment as well. And then I would also take the chance to look at things that, calculators that you might need to used to inform your choices about medication, using the CHA2DS2-VASc score in anticoagulation, choosing whether you want to anticoag someone or the risk of stroke, or, looking at the Q risk for cardiovascular risk. So, things like that. So there's things I would use too. So on this slide, it's really just a list of resources that I have listed, just in case you've not come across them before. Some of these resources I found really useful myself, so I thought I'd share them with you. Polypharmacy, the NHS Scotland 7 Steps of Medication Review. It's a really good tool. And then you've also got the SPS Stop It Medication Review tool. They're really good tools. High anticholinergic burden. There's a really good calculator created by Dr. Rebecca King and Steve Robinho. It's literally, you just type in the drugs and it calculates the risk for you. And then SLAM have a similar tool as well. And then you've got the Stop Start tool for the older persons, deprescribing tool perhaps. And then you've also got the STOMP tool for your learning disability patients. So if you've not seen these tools, they're really good to go and have a look. And even if you don't use them every time, it gives you a general gist of what you should be thinking about. So I'm just going to go through a few things that, when I do a medication review and my antennas kind of perk up when I see these drugs. So I thought I'd share some of my examples, and they're quite common, so that's why I've put them here. This is not an exhaustive list. This is just something to, think about. So if patients are on proton pump inhibitors, normally I'd want to go and check the indication and check whether they need to be prescribed long term. Obviously, if they're covering something like an antiplatelet, we might not be able to do very much with that. But if they're not, if they're just using it for, reflux, have they tried a time without the proton pump inhibitor, trying an antacid in its place for a few days and seeing how it goes. And this is really important because in your elderly patients, we know that the risk of GI infections and the risk of osteoporosis increases with age and the length of treatment. So it's something that we would want to look at. I would also look at any medications associated with any coroner's notice. And the example I've just chosen there, which was quite recent, was the amitriptyline and the oxycodone. And, it would remind me to go away and have a look at these kind of combination drugs and see what we can do there. The other one I put up there is dipyridamole. And the reason I put dipyridamole, especially in combination with aspirin, is this is no longer first-line treatment for your cardiovascular events. So, cerebrovascular events. And if they are being prescribed, that you'd want to double check that they're not able to take clopidogrel or aspirin or other antiplatelet therapy, and they haven't just been missed to be switched to the clopidogrel. And the clopidogrel monotherapy, that's in line with best evidence, but also it reduces their bleeding risk. So it's quite an important one to double check on. And then I would also be looking at any high-risk patients, such as people that are prescribed dual antiplatelet therapy or an antiplatelet plus anticoagulation, because obviously these patients are high risk, and you want to make sure that it is under the cardiologist's recommendation that they're on these high-risk medications and that they're being reviewed regularly, because obviously the cardiologist will prescribe them, and it may have been several years ago that they recommended this treatment, and since then things may have changed. So we always want to make sure that we review these patients regularly. The other thing I put up there is aqueous cream. So aqueous cream is not recommended as a leave-on emollient due to the potential damage it can cause skin. So if you are prescribing aqueous cream, it should be only for as a soap substitute. So remembering to change it to something like xeroderm. I'm just giving an example there, but anything that's on our formulary that can be used as a leave-on emollient. And then I would review things like DocuSay. There's not very much evidence supporting its use as a laxative. So I'd probably want to pick something that has better evidence, such as lactulose, senna, macrogols, any of those. Nearly everything has more evidence than DocuSay. So something that is proven to work. And then looking at patients that have high dose steroids being used and ensuring that, you know, we have issued the steroid cards and documenting these kind of things in the notes. Oral bisphosphonates is something that I always look at, because we know that after 5 years of treatment on a bisphosphonate, most patients will have a continued benefit for a further 5 years after stopping a bisphosphonate. So reviewing whether they need to continue would be part of you know, the meds review as well. It might not be that you stop it in the review. It might be that you go away and have a conversation, perhaps with another clinician at your practice, to decide what the management might be. But, you know, just identifying that, you know, that these patients have been on a bisphosphonate longer than 5 years on part of your review. And then lithium is always one that would perk my antennas. It has a very narrow therapeutic window, and as patients get older, the dose requirements change too, mainly because, you know, they have a reduced volume of distribution as you get older, and your reduced renal clearance as well as you get older. But also because, you know, patients may have started new medications since they've been prescribed lithium. And we know things like thiazide diuretics, ACE inhibitors, and NSAID can all increase your lithium concentration. So it's, and the other thing about lithium is, as you get older, your tolerability changes. So neurotoxicity even occurs in elderly patients at concentrations that are normally considered therapeutic in the general population. So, you know, just asking them about side effects that they might be having, you know, nausea, vomiting, confusion, all those things that you associated with lithium toxicity. I probably don't need to talk about NSAIDs very much. I'm sure all of you review NSAIDs, but long-term NSAIDs, you know, are associated with increased bleeding lists, but they're also, I particularly pay attention to them if they have, you know, things like cardiac disease, renal impairment, because they are particularly problematic in these patients. And then diuretic use as well. So long-term diuretic use for things like simple gravitational edema is not usually required long-term, because normally what you do is you use a diuretic to offload the patient's fluid, and then you would try and manage it with increased movement or raising the legs or support stockings and so on. But rarely do you need it for like long term. This is not for your obviously heart failure patients who would be on it long term, but these are just reviewing it for just gravitational edema. So that's just a flavour of some of the things I would be reviewing in SMRs. This slide is really to just, you know, one of the things that we should be mindful when undertaking SMRs in the PCN are that we are required to work with community pharmacists to connect patients appropriately to the new medicine service, and really it supports adherence to new prescribed medication. I'm sure Mohammed could probably give us a better explanation of what the new medicine service does, but it's useful to know that, you know, it supports patients currently with asthma, COPD, diabetes, hypertension, and newly prescribed anticoagulants and antiplatelets. And I think we can refer directly into this service, as I'm sure Mohammed will tell me if not. Is that right?
Yes, all that's to be indicated is new medicine service somewhere in the instructions or somewhere in the notes to the pharmacist on the prescription.
Excellent.
And what happens effectively with that, just to elaborate, is that the pharmacist, community pharmacist, checks with the patient a few weeks after they start if they're still taking it, are they having any problems, are they using it appropriately, and then follow up again another 4 weeks later, again to check that the patient is continuing to use it. With inhalers, looking at technique, etc. With blood pressure medications, again, seeing how they're getting on. So it's just a little backup to any new medications you might be initiating.
And that really is everything we're going to cover as an introduction to SMRs this time around. So the next time we plan on having a look at some case studies and introducing things like very brief interventions, making sure that every contact counts, that kind of thing. I hope you found what we said today helpful. Thank you for taking the time to listen to the presentation. We'll have a look at some of the questions, but I think Bola is going to help us by placing a link in the chat for some feedback. So I'll be grateful if people can take some time to do the feedback for us as well. Is there any questions, Mohammed, that people have come up with? I'm going to stop sharing if I can, so I can see people.
It's been remarkably quiet. There hasn't been anything that we haven't been able to sort of answer. But I'm sure there'll be more now. But Rima, would you like the feedback put up now or after the questions?
Yeah, now it's good, and then it gives people a chance to do it. Have I stopped sharing my slides?
Yes, you have.
Yes.
Okay, good.
Just to let you know, I'm going to stop the recording so people can feel free to ask questions and things like that. And I'm also going to put the Google form link on the chat. So you give me 2 minutes while I stop recording and get the link.
One final plea. Anybody who has not